So it is a pleasure to be with you again, and I will reintroduce myself. I'm McCormick, Pries. I'm a nurse practitioner. I work at Vera French Community Mental Health Center. I'm currently the clinical director there. And in May, I had my 40th anniversary working there. So I feel pretty proud of that. And I think one of the things for me that highlights is my passion in treating the mentally ill has really felt to me very much like a vocation. It is a call. And I share that passion with many of the people I work with. This has not been just a job. This has been a real calling for me and for many of my friends. Now, Mike is busy, so I'm going to move on to the next slide, and I'm going to just kind of come up and... There you go. So, one of the things that's important to remember is we talk about kind of treating the mentally ill, looking at the concept of mental illness in the overall framework of our Catholicism. There are several pieces of information that I think are very important that I want to kind of start with. One of them is that it is critical that we understand how many people really experience difficulties associated with mental illness. In general, the World Health Organization tells us that 450 million people in the world are affected by neurological and biological illnesses. This is more than the population of the United States. We also know that 873,000 people die by suicide every year. It's a terrible tragedy. In the United States, what that kind of measures out to is that about 11 or 12 people per 100,000 end their lives annually by suicide. And I'll be talking specifically about suicide and kind of the Catholic view of that as I proceed through my information. 1 in 4 Americans experiences a psychiatric or mental disorder. Probably the most common of which is clinical depression. Now what this means is you cannot go to church and not be directly affected by or directly experience what it means to have a friend or a colleague or a family member or an associate who experiences mental illness. And yet the interesting thing about that, as you sit in the pews, and think about this when you attend Mass, 1 in 4 people experience symptoms of mental illness. How many of those folks visibly display those symptoms? Occasionally some do. But one of the challenges to treating the mentally ill is that many folks suffer in silence, and they suffer with what some view as invisible symptoms, which makes treatment, understanding, and the approach to the mentally ill somewhat difficult. As Catholic care providers, how are we called to action to help those who suffer, those of our faith as well as others? And I'm on the slide before this, and I apologize. But I want you to remember that as Catholic healthcare providers, we offer our care in a context that may be perhaps somewhat different than the context that other healthcare providers offer care. As many of you know, this is a year that the Pope has asked us to focus on mercy. And he has asked us to be especially mindful of both the corporal and the spiritual works of mercy. These are tenets, these are pieces of my philosophy and the philosophy of many I work with that are very important, a very important foundation in how we approach the mentally ill. I know all of you know the corporate and the spiritual works of mercy, but I want to run through them quickly because they definitely speak to the care of the mentally ill. Feed the hungry. Give drink to the thirsty. Clothe the naked. Welcome the stranger. Heal the sick. Visit those in prison. And bury the dead. Spiritual works of mercy include counseling the doubtful. I'll speak to you in a minute about some of the statements that St. John Paul II has made regarding some of this. Instruct the ignorant, admonish sinners, comfort the afflicted, forgive offenses, bear patiently those who do us ill. That's a hard one. And pray for the living and the dead. The spiritual and corporal works of mercy, as well as the Beatitudes, for many of us who are Catholic and Christian, in mental health, help guide our interventions and our thoughts about those that we care for. If we are faith-filled, and if we understand the spiritual and corporal works of mercy and the Beatitudes, it helps give us a springboard for the rest of our work in working with the mentally ill. I propose that there are 4 areas of thought for us to consider as we try to seek a greater understanding in treating and understanding the mentally ill. And I want to look at kind of 4 areas as I walk through the presentation today. I want us to look a bit at the patient, the family, the healthcare provider, and the community at large, including our church community. Now we're at this slide. Don't touch it. Don't touch it. We're right there. Okay, important for us to remember that Christianity in general has a pretty mixed history with regard to dealing with individuals who are mentally ill. Please remember many of the early hospitals that were set up to treat both those with physical as well as psychiatric illness were set up by religious orders, were set up by individuals who came together with a central theme of offering care and kindness to those who were in difficulty. I think our faith, as you can see, has fundamentally valued individuals as being inherently worthy because we are made in the image of God. We are made in the image of Christ. When practiced correctly, then, our faith leads us to compassion and care for those who are disadvantaged, weak, or ill. Jesus said, and this is something that all of us think about daily, "Truly I tell you, whatever you did for one of the least of these brothers and sisters of mine, you did for me." And I know at one point you had a speaker come and talk a little bit about Haiti. If any of you have been to Haiti, I think it was Mark Blanche that probably did that. And I've been on a mission trip with Mark and have gone to Haiti. And it's very interesting because our last day in Haiti is spent at the Matthew 25 house in Port-au-Prince. Again, the theme being, care for those, brothers and sisters, and you are following my word. You are following my tenets. Okay. When we see a patient with mental illness, we're often tempted to say something like, pull yourself out of it, get yourself together, stop thinking about what's happening. Get interested in something. Spend some time doing something different. It's very important, and I'll speak specifically about depression first. It's very important to understand that depression truly is a medical illness. It is not a weakness of will. It is not a failure of faith. It is not an inability to see God in our world. It is truly a medical illness. Encouragement and regular pastoral counseling is very important in treating those with mental illness. But more severe mental illnesses need medical help. Simply talking to people, simply offering spiritual exercises is not enough, although it is a component. Speaking about depression specifically, it's very often misunderstood, and it's kind of seen as that prolonged sadness that many of us have experienced. No one in this room has escaped the feeling of sadness. Sadness at a loss, a disappointment. Sadness because we have not been able to fulfill something that we've wanted to do. But depression, in fact, is much more complex than that. And it really profoundly impairs individuals in many, many, many ways. Many individuals with depression, as well as bipolar illness, anxiety, obsessive-compulsive disorder, post-traumatic stress disorder, schizophrenia, suffer in silence, and oftentimes their pain goes unrecognized. With cancer, patients are flooded with support. I once had someone say to me, you know, if my brother, my mother, or my child had cancer, people would be bringing me casseroles, they would be having fundraisers, they would be offering me support. Mental illness is a no casserole illness, which I thought was profound. How many times do we offer a casserole? Comfort, visitation, respite, time with individuals who experience mental illness. We don't typically, because of the years of stigma that have been associated with all of this difficulty. Okay. We know that depression is complex, and it really affects the way we think, the way we behave, and interestingly, it affects our body. We don't sleep well, we don't eat well, we don't digest well, we're restless, we're lethargic, we're slowed. The causes are complex and multiple. And as you can see from the slide, you know, we really have to pull together all that we know about this individual in order to really understand what brings them to this point in their lives, what brings them to their depression. And the one factor that is often left out, because many of us work in secular organizations, many of us work with individuals who are not faith-filled, but very often we forget or we're uncomfortable talking to people about the spiritual factors that are a significant part of their illness. And this is true not only in mental illness. This is true for those who are dying. This is true for individuals who experience any chronic illness or any acute illness. So it is incumbent upon us as Catholic healthcare providers to really incorporate what we know about neurobiological, genetic, social, interpersonal, cultural, and spiritual factors as we involve ourselves in the care of individuals. When we speak of depression or any other mental illness, it is very important that our treatment incorporate all of these perspectives and all of these factors. Accurate diagnosis is very important with regard to depression and other mental illnesses, and that's really our first step. And in accurately diagnosing an individual, and in providing them with medical as well as psychological, spiritual, cultural, social assistance, we can help clarify if there are medications that might be helpful. In the case of depression, very often antidepressant medication or mood-stabilizing medication if the depression is diagnosed to be the depressive component of a bipolar disorder, those medications can be helpful. Even somatic treatments like ECT, electroconvulsive therapy, which many people are very frightened of and feel, oh my goodness, that's barbaric. It's really not. It's really not barbaric at all. And in fact, many individuals experience a quicker recovery with fewer complications through the use of ECT, both in the acute phase of their illness and then later as part of the maintenance phase. But without dialogue about how these treatments can work, and without openness in introducing these topics and discussing them, our patients don't have the advantage of being fully informed about what is available to them. Compassionate and knowledgeable treaters, psychiatrists, nurse practitioners, psychologists, social workers. We also have supported community living workers, mental health techs, pharmacists, primary care physicians, nurses in primary care offices, school nurses, all of these individuals who are both compassionate and knowledgeable can be very helpful in encouraging patients to engage in good evidence-based treatment that can help reduce the symptoms and the impact of the symptoms of the difficulties that they are experiencing. And there are multiple evidence-based treatments that are very, very good. A few that I will share with you: cognitive therapy. Cognitive therapy. I have been asked often by patients, well, what is cognitive therapy? And often I will say to them, cognitive therapy is the type of therapy that really helps you understand it's not what's happened to you, it's how you think about what's happened to you. That's the focus of our treatment. So cognitive therapy works on cognitions and the resulting behaviors that occur because of how we think about and then feel about something. DBT, dialectic behavioral therapy, teaching people about their illness. There was an excellent article, and I just thought of it now, I forgot to reference it in this, but there was an excellent article written by Nathan Lippincott, and for any of you that have had medical and nursing textbooks, you know the Lippincotts have published all of these things. Nathan Lippincott is a member of the Lippincott publishing family, who was plagued for years with chronic depression and chronic suicidal thoughts. Finally, he was treated by a physician and a therapist who were both aware of DBT and appropriate medications. Through the use of dialectic behavioral therapy, which has 4 components or dimensions to it: mindfulness, emotional regulation, assistance with looking at interpersonal skills, and teaching people distress tolerance. Through the intervention of a therapist and a physician who were aware of DBT therapy, he was able to come through the darkness of his depression. And he wrote a very interesting article that was published in the New York Times called "No Longer Wanting to Die." And it was a wonderful article written by a non-clinician about how effective DBT was. So evidence-based treatment, good treatments are very important. The other thing that we know, and many of you are aware of this, I'm sure all of you have heard of the ACEs study, adverse childhood events that had caused trauma to individuals. And one of the things we know about individuals who have been terribly traumatized is they don't behave in the ways we'd like them to. Sometimes they don't engage in treatment, sometimes they are angry and upset, sometimes they don't benefit from conversation because they don't trust, they don't feel comfortable. To have trauma-informed care infused in the office setting becomes very important in helping people with mental illness. It's a very compassionate and a very important concept to remember. Dealing with everyone, thinking, we don't know what battles these individuals have been fighting. Let us be kind. Now, doesn't that sound like a good Catholic philosophy? Let us be kind and welcoming. And trauma-informed care really starts with welcoming individuals from the moment they call us for their first appointment to the time they check out in the billing office or in the scheduling office. So all of these things are very, very important. In a 2003 address on the theme of depression, St. John Paul II said that depression is always a spiritual trial. To specifically quote him, he stated, "This disease is often accompanied by an existential and spiritual crisis that leads to an inability to perceive the meaning of life." How true is this? And I worked with a psychiatrist for years, very compassionate psychiatrist, who always reminded me, Chris, people need to have purpose and meaning in their lives for their lives to be meaningful. We can always have purpose and meaning even if we are mentally ill. Our job is to help our patients find that purpose and that meaning in their lives. Many people who experience severe psychiatric disorder have lost that sense of direction and purpose and meaning in their lives. The Catholic healthcare worker, with what we know and with our spiritual background, is really encouraged to reach out and to explore this despair with the patient and to try and find out with them, what were they meant to be? How were their lives meant to be? What does this illness mean to them? Okay. Furthermore, in a conversation with psychiatrists in 1993, again, John Paul II, he had quite a love of working with healthcare providers and quite a love of individuals with mental illness. But he pointed out, and I quote, "By its very nature, your work brings you to the threshold of the human mystery. It involves sensitivity to the tangled workings of the human mind and heart and openness to the ultimate concerns that give meaning to people's lives. And there are a variety of ways that we can help people with this. Many times people come to me, and I primarily prescribe these days. I don't do a lot of psychotherapy anymore, but for the first 20 years of my life at Vera French, I was a psychotherapist. And in evaluating and engaging in treatment with patients, often I would say to them, when they would share their secrets, their burdens, what do you need to do to make this right? Let's explore that. How can we make this a better situation for you? Often that would lead into a discussion of their spiritual despair and the spiritual desert that many of these patients have walked through. And this would promote the opportunity then to begin really deeply talking with them about what their spiritual, their internal lives were about. It's very important to remember, as John Paul said, and many have quoted since then, the confessional was never meant to cure neuroses, which, by the way, is kind of an old-fashioned word. We don't really use that word anymore. But the confessional was never meant to cure neuroses, and the couch was never meant to absolve sin. So we each have a role in helping individuals, and it's important for us to dialogue and be clear about what our role is. When referral to a spiritual director or a priest is something that patients are open to, or their own minister, whomever that might be, that's something that I choose to do. And again, many of my colleagues choose to do that also. Really engaging in that dialogue, in that dual relationship. Okay. We also know that some very severe depressions can lead to such despair that the individual sinks into really profound and painful hopelessness. Occasionally, this is accompanied by delusional thinking about oneself, the world, and the future. And you know, as I have progressed through my career and seen many people with many different symptoms related to psychiatric illness, one of the most difficult symptoms for me to help resolve, and I think for patients to deal with, are those constant delusional thoughts that folks have. They don't respond well to medicine. And delusional thoughts are basically false beliefs. Hallucinations, remember, are perceptions. They are perceived by our senses. We have visual, auditory, olfactory, gustatory, and tactile hallucinations. These each correspond to the 5 senses that we have. Delusional thoughts are false beliefs. For many people with delusional thinking, first of all, they're fearful of sharing it because, of course, you'll think I'm crazy. You'll make me go to the hospital, which for many people is a total loss of control. So when folks do begin to share these ideas, it is very difficult to help them. And we try to teach people to challenge delusional thoughts. But I want to propose to you, if you deal with patients who have delusional thinking, it is like mental torture every day to be, to quote a word, obsessed with or consumed by beliefs that are unreal, that often have to do with harming me or harming those I love. It's a terrible thing for many of our patients. Even when we know that folks are driven by this despair and these torturous delusional ideas, death by suicide can often come as a shock to us. And I think probably one of the experiences that we all have had was the recent death of Robin Williams.
Yes.
I mean, almost everybody, if you knew anything about Robin Williams, you knew he battled with depression and he battled with substance use. In fact, at one point in an interview many years ago, he used to say, "When I am performing, I don't take my medicine because my medicine slows me down." And my goodness, he had a quick wit, didn't he? Robin Williams was loved loved by people, and he knew he was loved. Even that could not insulate him from that final despairing moment where he took his own life. For many of us in the mental health field, another individual that experienced such a despairing loss like this was Rick Warren. Many of you may know Rick Warren as the writer of A Purpose-Driven Life. He is the pastor of Saddleback Church in Southern California, where he has, I think most priests would be envious of this, he probably has 30,000 people in his congregation. It is not unusual for 3,000, 4,000, or 5,000 people to come weekly to services. He's also been the inspiration behind the Daniel Plan, which is a health and wellness plan. Rick Warren's youngest son, Matthew, killed himself in April of 2013. Rick and Kay Warren were devastated by this. Had always known that he was mentally ill, probably had bipolar disorder. Had always known that, had had discussions with him about suicide. He knew he was loved, and that was not enough to keep him from ending his life. His despair was so overbearing. The pain that he experienced was so overbearing, he saw no way to end it except to end his life. And that really is what suicide is about, by the way. It's not about dying. People don't think, do I want to die or not want to die? I mean, that's kind of a consequence, but that's secondary. The issue is, I cannot bear this pain any longer. I cannot bear this agony any longer. There is no light at the end of this tunnel. And this is where it becomes so important for us to help carry this burden of hopelessness and despair, and to help connect people spiritually, either within the context of our treatment or to help get them connected to pastors and ministers that can help them with this despair. Okay. We know with regard to suicide that the Catholic Church has a morally clear but pastorally sensitive teaching on suicide. Now that almost seems like an oxymoron, doesn't it? It's morally clear, but it's pastorally sensitive. And basically what the Catechism says, and I've given you the reference, the Church teaches that suicide is indeed a sin. It's a sin against the love of God, the love of myself, and the love of my neighbor. On the other hand, the Church also recognizes that an individual's moral culpability can be diminished by mental illness, especially despair and hopelessness. Grave psychological disturbances, and this is where those torturous delusional thoughts, the black darkness of despair and hopelessness, grave psychological disturbances, anguish, or grave fear, fear of hardship, fear of more suffering, fear of torture, can diminish the responsibility of individuals committing suicide. And you know, finally, the Church has allowed Mass and burial in consecrated ground for individuals who have committed suicide. For years, that was not permitted. So adding to the anguish that a family had of losing someone, they were shunned by our Church. They were shunned by our Catholic teachings because they were judged to have committed a grave sin. That's not helpful. What has been helpful is the reevaluation of that perspective within the Church and the embracing of families and the suffering with them for the loss of a loved one that they have experienced. Families and friends also have a great deal of difficulty with regard to mental illness. Remember, spouses, children, parents, friends who are trying to help a loved one are often puzzled by their impairment. Again, unlike cancer or broken bone, there's a stigma, and symptoms of the illness are often hidden from sight, or if they are displayed, we judge and evaluate them. Sometimes symptoms include restlessness, anger, irritability, unpredictableness, withdrawal, a lack of energy or an ability to engage in conversation or just regular living around the house. It's very difficult not, as a family member, not to become discouraged, angry, and sometimes wonder, is this all for attention? Why are they acting this way? What is this all about? Family members often don't know how to ask for support or assistance. And the other thing that's important to remember, there are ways to get around this, but often confidentiality legislation seems to prohibit conversations between treaters and family members. So it becomes important for those of us treating individuals with a mental illness to talk early on in treatment. Who cares for you? Who loves you? Who supports you? Who may I talk to help get you the treatment and the support that you need? And then, by gosh, have that individual sign an authorization to communicate with a family member or a friend. That's all it takes. Individuals are reminded, you can renege this at any time. But this is helpful. We are not an island. We do need to have people help us. So getting those consents is very important. Friends and family often feel ambivalent and uncertain about what their outreach should be to their family members or to their congregants, other congregants within a church, if they know there's a psychiatric disorder. You know, one of the things that is very painful when individuals lose a family member by suicide, often people are afraid to say the S word. They are afraid to console them, afraid that it may cause more pain. I'm here to tell you, in fact, it is helpful and reassuring to let people know that you care about them and that you don't judge them if their family member has suicided. Many families who have lost a family member by suicide think their friends, their neighbors, their church, their doctors, their healthcare providers will think they did something, said something to push the individual over the crevice or the cliff to choose suicide. In fact, we need to be given permission to talk about this. And sometimes that's the important step to take. I'm here, offering those things that often we offer when the death has been by cancer or by car accident. Becomes very important. I was really struck recently by something I was reading related to Pope Francis. And he talked about how important it is to welcome individuals into our church. And my goodness, there's been a lot of controversy about that lately, hasn't there? We need to welcome people. And Pope Francis said, sometimes the church is like a field hospital during a war, which, when faced with a seriously injured person, you just have to heal his wounds. Before you start instructing, teaching, telling, it's important to welcome and help people heal. And this is so true in dealing with family and friends when individuals have been mentally ill. For us healthcare providers, we have to be knowledgeable and confident in conversations regarding the mentally ill. And the first area of knowledge and confidence needs to be, yes, this is a legitimate illness. This is a legitimate biological illness that is very complicated and has other factors that also include spiritual factors, social factors, cultural factors. But we need to legitimize the pain and the suffering that individuals with mental illness have. For too many years, they've been thought of as being lazy, attention-seeking, and not having enough faith, which is such a disservice and such a negative way to look at individuals like this. We have to continue to fight the stigma and misperception that mental illness is the result of sin, weakness, or a lack of faith, and that it's not a real illness. And as we engage with our patients, it is important to be open to and aware of the need to ask about the spiritual aspect of folks' illness. I often say to people as I address this with them, tell me what you're most afraid of. Tell me what is most bothersome to you. I would think not being able to sleep. I love to sleep. I put my head down on my pillow and I fall asleep, and I'm so grateful for that. But many of my patients don't sleep. I would think that would be the worst symptom. I'm surprised sometimes when I ask them. Ask people, what is most difficult for you? What are you most afraid of? Don't be afraid to bring up spiritual beliefs. What are your spiritual beliefs? Do you find comfort in your church? Do you find comfort in God? Do you find comfort in your congregation? Are you a congregant of a church? And I have patients that come from many religious backgrounds, but many, many, many of them want to talk about their belief in God and their fear and their concern sometimes that God has abandoned them. And it becomes important for us to be able to address that and to talk, not to forgive sin on our couches or our chairs, to direct people to the spiritual resources they need, but also to be able to talk about these things. I pray with my patients. I have a copy of the New Testament in my office. And there are times when we read specific psalms. We read specific prayers. I have a colleague at work that I pray with. Once a week, we pray for our patients. It is well known that prayer, even for those that we are not praying with directly, but we are praying about, intentional prayer, we can help heal their wounds and help heal their illnesses. Okay, based on the numbers that I reviewed earlier, 450 million people with psychiatric disorder. 1 in 4 Americans with psychiatric disorder. It is important for us to remember that the members in the pews in our parish, the individuals on our parish council, those who volunteer within our parish, have in many ways directly experienced psychiatric illness. By virtue of baptism, we are all equal members of the church, and we need to be mindful of that. We have a young man in my parish who has very severe Tourette's disorder, and he tics all the time. And it is very interesting to see how people respond when they're sitting next to him, in front of him, or behind him. Very often moving away, not wanting to hold his hand during prayer. So not only does he have this terrible disorder, but even in the context of our church, we reinforce the alienation that he experiences by not approaching. It becomes very difficult. We also know there are many members within our church who are quite depressed. And yet, sometimes we're puzzled about how to approach them. Okay. There is a very interesting and kind of up-and-coming young psychiatrist by the name of Aaron Caherity. Aaron Caherity practices in California. He received his bachelor's degree from Notre Dame in theology. And then he went to medical school at Georgetown University, and he's written a couple of books, but he's written a wonderful book. And his book is, I just forgot the name of it. I think The Catholic Approach. Oh, thank you. Catholic Guide to Depression. Thank you very much. Catholic Guide to Depression. And he's got some wonderful things to say about our faith and encouraging individuals within our faith and within the Christian community to look towards their religious and their spiritual community for assistance in helping them when they experience mental illness. Sacraments alone were never meant to cure mental illness, but they can and do play a healing role in our recovery. The Catholic Guide to Depression. He reminds us that the physician or the healthcare worker and the priest do work hand in hand to heal those who suffer. He goes on to say that if a patient is burdened by guilt, by sins of the past, which very often is part of depression, exploring the issue of reconciliation or confession with them becomes important. And it becomes a very tangible way to hear words of absolution from the priest who's acting in the name of Christ. The other thing that we know is that in confession, as we are absolved of our sins, as we are welcomed into the grace of God, there is a sense of reintegration with the community, which becomes extremely important. Participating in Mass and encouraging our patients to participate in Mass helps unite us with the suffering of Christ and helps give meaning to our suffering. In Holy Communion, we receive the flesh and blood of Christ. We are redeemed and healed. And it's not a magic cure, as we know, but it does strengthen us and allow us to better bear the burdens that we are experiencing in our lives, and to join with Christ. Again, Pope Francis, inspirational in so many ways. His message of welcoming to all the church, to heal the wounds, is a message that resonates with what I think is becoming a prevailing value of good mental health care. And this has not always been a value of good mental health care. In fact, like cancer many years ago, remember many years ago, at the turn of the century, if someone had cancer, it was like, okay, well, whatever, you're going to die of cancer. You know, it's a bad disease. Look at our view of cancer today. With mental illness, it's been very much the same. Often we have said to people, well, you got bipolar illness, you got schizophrenia, you got schizoaffective disorder, your life's going to be miserable. We didn't say it in that many words, but what we assumed was that there was no hope for people to live as fully as they could. There truly is a belief and an incorporation of the spirit of recovery in mental illness. And I don't mean recovery like we mean when we talk about strep throat. I mean recovery in the context of being able to recover those pieces of my life that have been lost to me by my illness. This type of recovery is a belief that everyone has promise and can recover and rebuild from life's misfortunes, and should be able to have what we all want. And that really is a very universal feeling. What do we want? We want relationship, friends, connections, companions. We want the safety of a home. We want the experience of being welcomed into a community. And we want the dignity of being able to contribute. In other words, we want purpose and meaning in our lives. It is our faith and the living of the tenets of our faith that help us to be better clinicians and to provide what may be more important than anything else. And what is more important than anything else, in many ways more important than the medicines, the CBT, the DBT, the trauma-focused care, the ECT. What is critically important and what our faith allows us to do is to foster hope and to help to heal the wounds of those devastating illnesses as part of those experiences that the mentally ill have. And I think I want to end with two things that I think are critically important, and that is, for me, I'm sure everyone here reads Scripture every day. For me, one of the Scriptures that I have found so helpful, and that I have often said to my patients, is a Scripture from Jeremiah. For I know the plans I have for you, declares the Lord. Plans to prosper you and not to harm you. Plans to give you hope and for a future. That is from Jeremiah 29:11. The other thing that I think is important, many individuals with psychiatric illness and many other illnesses believe that God can't love them. Truly believe they have erred so badly. They have wounded others so badly that God can never forgive them and bring them into grace. And one of the things that I think has been helpful has been the ability to talk with patients about the fact that the last thing that Christ said on the cross, the last thing he said was, "It is finished." And what he meant by that, I think, is that the debt of our sin has been paid in full. We are welcomed into Christ's love. We are welcomed into God's love. We don't have to do good deeds for it. We are just invited to ask for it. And for many of my patients, that becomes a very important beginning in their journey of hope and recovery. So I thank you today and would welcome any questions if you have any.